Each MyEMCert module includes a section with questions based on key advances relevant to the practice of emergency medicine. In this video, we will take a closer look at the key advance synopsis based on the 2020 ACOG Practice Bulletin on Gestational Hypertension and Preeclampsia. The synopsis is titled, Emergency Department Evaluation and Management of Hypertensive Disorders of Pregnancy. Hypertensive disorders of pregnancy include chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia or eclampsia. This key advance will focus on management of gestational hypertension, preeclampsia, and eclampsia. Kelly is a 32-year-old woman who is 34 weeks pregnant and presents to the emergency department. She injured her left middle finger swatting away a basketball while watching a game at her local community center. Her vitals are taken and an X-ray is ordered. The X-ray reveals a hairline fracture on the proximal phalanx of the middle finger. Her initial blood pressure reading is 165/100. After pain control, a repeat blood pressure reading is done, which reads 160/88. The patient has no previous medical history and is experiencing no additional symptoms. Labs, including CBC and basic chemistry, are normal. UA shows 2+ proteinuria. The alanine transaminase, or ALT, is 110 units per liter, and the aspartate transaminase, or AST, is 98 units per liter. What are the next steps in managing this patient? Vicky is a 35-year-old woman who is 1 week postpartum and is complaining of intense headaches that have been on and off for the better part of the last week. She has tried acetaminophen but has had no improvement. Her vitals are assessed and Vicky's blood pressure is 165/110. Her blood pressure is repeated within 15 minutes and is 160/95. Blood is drawn to assess renal and liver function and platelets. A urinalysis reveals proteinuria. Does this patient require emergent treatment for her blood pressure? Gestational hypertension is a condition where a woman who has historically had normal blood pressure develops hypertension exceeding 140 millimeters of mercury systolic or 90 millimeters of mercury diastolic during or after pregnancy. Typically, this condition arises after 20 weeks of gestation. Risk factors include age of 35 years or older, pre-pregnancy BMI over 30, thrombophilias, or a history of diabetes, hypertension, or renal disease. Other risk factors include having previously delivered twins, a family history of gestational hypertension, or placental abnormalities. Typically, hypertensive disorders of pregnancy, which include gestational hypertension, are characterized by sustained high blood pressure, often with symptoms of headaches without another clear cause, nausea and vomiting, vision changes, weight gain, and edema. Diagnosis is determined based on the severity of the hypertension, as well as urine and blood test results. Gestational hypertension is diagnosed in patients at more than 20 weeks of gestation who have systolic pressures above 140 millimeters of mercury, or diastolic pressures above 90 millimeters of mercury on 2 measurements at least 4 hours apart in women with no prior history of hypertension. Following a gestational hypertension diagnosis, the patient should be further screened for severe features. Preeclampsia is the diagnosis when blood pressures indicate gestational hypertension and one of the following conditions is met. Urinalysis results indicate proteinuria, or examination and labs reveal the presence of thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or a headache that is unresponsive to medication. Preeclampsia is considered severe if the patient has any of these conditions or has 2 blood pressure readings that exceed 160 millimeters of mercury systolic or 110 millimeters of mercury diastolic. If the patient has progressed to experiencing seizures, eclampsia is the diagnosis. In all cases of severe preeclampsia, treatment should be delivered within 30 to 60 minutes of the diagnosis being made. Patients should be administered antihypertensive medication, such as labetalol or hydralazine intravenously as a first-line treatment, as soon as reasonably possible. If IV access cannot be obtained, oral nifedipine can be used. In addition to antihypertensive medication, patients with severe symptoms should receive magnesium sulfate to prevent or treat seizures. If IV access is available, a loading dose should be given before starting a continuous infusion. If IV access is not available, repeated intramuscular injections should be given, mixed with lidocaine to decrease pain at the injection site. As a quick recap, hypertensive disorders of pregnancy includes 3 categories for women with new onset hypertension during pregnancy or postpartum: gestational hypertension, preeclampsia, and eclampsia, depending on the severity of the hypertension and the presence of accompanying symptoms. Patients without severe symptoms should receive treatment with antihypertensive medications. Patients with severe symptoms should be managed with antihypertensive medication and with magnesium sulfate to prevent and treat seizures. In the given scenarios, the emergency physician assesses each patient and finds they are both hypertensive and have features of severe preeclampsia. It is determined Kelly has preeclampsia. Although she has no symptoms, the height of her blood pressure, elevation of liver function tests, and proteinuria indicate severe preeclampsia. Per the current guidelines, she is administered labetalol and magnesium, and obstetrics is consulted for admission. Vicky is postpartum, but has symptoms of preeclampsia with severe features, which include a headache that is unresponsive to medication and proteinuria. Per the current guidelines, Vicky is administered antihypertensive medication and magnesium sulfate intravenously to prevent further deterioration, and is admitted to the obstetric service for continued management of the hypertension and seizure prevention management. Learn more about MyEMCert and key advances at www.abem.org.